Great. Good afternoon, everyone. Let's go ahead and get started. We have a packed agenda. It's just after 12, and I'm sure others will be logging in, but we'll honor the time that you guys were here on time. I'm going to go ahead and turn it over to, I'm not sure who's leading, Tina or Kathy. I guess Tina is with data, right?
Sure, let me just walk us through the agenda and then we'll get started with measurement with our measurement data guru, Tina. So that'll be our first start, and then we're gonna debrief from the homework that you all did. Thank you for those that were able to submit homework. I love looking at your work, so it's really great. Then we're gonna be talking about really drilling down in the transition between the root cause, what you prioritize, and designing PDSAs. We'll talk a little bit more about that. And what we're going to do is we're going to explore your homework with a special lens toward PDSAs. And so I think the teams for which I had homework that came on time, I looked and I've included you. So I don't want to startle you, but if you see your name come up, I may call on you just to try to help us understand your homework and how you're thinking about it. And we hope by the end of today, you'll have some really concrete ideas about how to take that area that you prioritize and design some meaningful high leverage PDSAs. So that will be our goal. And with that, we're just the measures as we talked about, the root causes, we're gonna homework debrief, and then talking about root cause to PDSA. So that's what we hope to take from today. And I will turn it over to Tina to talk about data.
Right. Thanks, Kathy. I'm on. Yes, I'm not on mute. Okay. Data. What slide? Can you go back? Uh-oh. This looks like. Can I maybe share my screen?
Yep.
Okay, perfect. Share. Just looking around different screens. And do you guys have the right view? It's in presenter view?
It's the presenter view.
Okay, good. Okay, thank you. So let's see.
Not slideshow view, right?
Like, do you see what you want to see? I don't know.
No, I see the presenter's view with the next slide and the notes.
Okay, let's swap that over so you have a full view. No, that's not right. Sorry, guys. There we go. Is that better?
There we go. Perfect. Okay. Thank you.
So I actually do want to use some of these notes because I want to highlight some of the data that we're seeing this month, which is really exciting. So in preparing for this call, Kathy had shared with me this press release on a nationwide survey. It was conducted by the American Diabetes Association, and it described how the financial and the economic toll of the pandemic has left a lot of Americans with diabetes without access to the drugs, the devices, the insurance, and the food that they need to properly manage their diabetes. And I'm sure this is probably familiar, and your observations are mirroring this. And so the authors of this issued a prescient warning that while the data focuses on the circumstances faced by people with diabetes right now, there may in fact be long-term repercussions for the health of these individuals, as well as considerations for you fine folks about the future need and demand and strains on our healthcare system. And I share that because from the lens of the Improvement Advisor, I think it's incredibly timely what you're doing to be routinely measuring and monitoring the health status of this population, to have this data to be able to empower your clinical health teams with information that they can use to better design systems and be able to respond proactively to the needs of your population. So when I look at this first shared quality indicator, hemoglobin A1C poor control, I think what we're seeing right now, just with some early data, is a stable system. And when I say stable system, what I mean is I don't think there's any deterioration in the quality of the performance or improvement just yet. Now, you'll notice it kicks up there in January. But if you look down at the table at the bottom, you'll see that there's only 3 data points in January. And so we just kind of want to be mindful of that when we're taking a look at this pooled data, and know that it's quality improvement data. Now, we can, when we drill down to the team level data, we get a lot more insight into what's going on. When I look at these, what I look for is, are there teams that are missing data? We know that early on, this is fine, teams are getting online, but at this point, as we're in the active improvement phase, it's really critical for you to have this data to know where you're at with your teams. I also look for concerning directions in the data and wonder what's going on there, ask some questions. I look for outliers. Maybe it's just something that got reported strangely in Excel. But I also like to look for, are we seeing any improvements or signals of early improvements in the data? And so on that point, I just wanted to draw everyone's attention to the first run chart in the series, this one from Cascade. And I think we have Whitney and Christiane on the line today. This one stands out to me because I noticed that with 6 months of data observations, the team consistently has fewer than 10% of their patients in poor control. They have about a patient population of about 400. I wonder, Whitney or Christiane, if there's anything you wanted to share on that point, if you have any observations, if you've done anything differently, or just anything to share.
Hey, this is Whitney and Christine, actually in the same room. Really, the only thing that we do with it, we just have a recall system in our EMR, so we just make sure that we stay on top of these patients and give them a call or send them a letter, and just try to stay on top of their care. There's nothing special really that we do. Maybe we got lucky. Good patients cooperate.
Well, there's probably a lot more to your system, but that's great. Thank you for sharing that. Okay, so moving forward with some of the data, we also know that the rates of depression have risen, and the burden is borne by economically and socially marginalized groups for the large part. And again, I think this really underscores the importance of the work that you're all doing. I really want to emphasize how critical it is as a starting point to work from a place where you know your population and you are consistently seeking to know the health status of that population. And from that place, we can work on a lot of things that are within our control. Things like, among those that we're reaching, how reliably does our system provide the best standard of care? Who are the people we need to reach, maybe by outreach, by video or phone to reach them? How are you working together, behavioral health and primary care, and maybe how can you use trauma-informed approaches? So we're seeing changes being described in your narrative reports that are working on this. Don't forget about the change package that has a lot of these change ideas in them too, if you're still struggling. And then of course the process you're working through now with the root cause analysis, and then moving from that to prioritizing and developing testable change ideas. So again, quality measurement and monitoring really helps us understand where we're at and where we're going as we're introducing the changes into our system. And considering the number of teams with data that varies across the bottom table, as I mentioned last time, I think this too is probably looking like a stable system. Time will tell as we have more data, but this also shows that we have a pretty good improvement opportunity here. With a median of 56%, we have lots of room to be able to make some gains. So drilling back down into the individual team level data, I'm really curious about run charts from CBHA. They have a median of 76%, and 5 consecutive points all going up, which is very interesting to me, and maybe a signal of some early improvement. And CVCH with 6 consecutive points all going up as well. Anything from those teams, anything you want to share about what you're doing and maybe what's working?
From CVCH, we're putting more efforts on our initial intake and standardizing that across the board. So we're getting more consistent depression screenings. And that's obviously, you can't follow up if you haven't done a screening. And so that's one of the things we are especially looking and going to be more with our adolescents as well. So I think are going to make the best gains there.
Great. And was that something you were measuring before the population health link in this way?
We hadn't done PDSAs to improve our intake process, but we were measuring before.
Awesome, thanks. Okay, and last one. Still, again, lots of variation in the number of teams reporting. You can see that along the bottom row of the table. But I do think this is quite interesting because right now we have 7 data points and they're all going up. Now, the last one is a little suspect because we only have 3 teams in the January month. But still, I think this is a promising story and potentially a signal of improvement. And time will tell again when we have 10 data points to be able to apply our run chart rules, but I think this is a good news story emerging. When we drill down to the team level data, you can see there's a lot of individual level variation and still a few teams missing data. There's a few teams with consecutive data points increasing like we talked about. There's a few that are still missing some data and others that are fairly stable and well above the pooled median. So this is a great opportunity to take a look at your peers' run charts, take a look at where they're at and ask some questions, not only about your own performance, but about theirs, about what you might be able to learn from them. And so just a couple final remarks from me is to keep up your measurement and to use this data to really understand how your system is working and if your system is responding in the ways you want as you're testing your changes. For teams that still don't have their data, please lean on your practice facilitator to support you to get up to speed as quickly as you can. Use this to reach across the table to find peers that you want to connect with. Keep measuring, keep testing, keep learning, keep improving. And if you have any questions about the data, you can always connect with myself. You can connect with your practice facilitators or anyone else on the faculty team. Any comments or should we just move straight forward?
Tina, can we just talk about on the team score and the narrative reporting, we've talked about some of the data points signaling the improvement, but that the run chart rules of 10 points to move you from that 2.5 to 3 while we're talking about data?
Sure, so just a clarification about that level?
That'd be great.
Yeah, okay. So Wendy's talking about the team assessment scores, or I forget what we specifically called them, but they're that sort of 0 to 5 score that each of the teams can sort of self-assess, you know, where are we at in our improvement journey and use that to plan. And so there is one jump from 2.5 to a 3.0. That one's a tough climb because to move forward into a 3.0, we look for the objective criteria is a signal of improvement in your data and a signal of improvement using run chart rules. And one of the tough things about that is that you need actually 10 data points, 10 observations to actually even be able to apply the run chart rules. Some of you have probably 7 data points, maybe some have more, yeah, unless you get 10, you can't really apply those run chart rules, and technically you wouldn't be able to reach a 3.0 just yet, but absolutely aspirational and in time, something that is achievable for a lot of teams. If you're looking to accelerate your ability to see improvement faster, Some things that I've seen teams do is you can start tracking data weekly or every 2 weeks. You can look for more retrospective data if you think that might give you a bit more information about your improvement. And that's probably it. Other than that, just keep measuring. Wendy, does that answer your question?
It does. Thank you.
So Tina, you're welcome to continue with the slides, or you'll need to stop sharing.
Yeah, I'll stop sharing and give it back to you.
And do we have slides up?
We
Homework
do.
debrief? Okay, great. All right. So again, I love looking at your homework. I saw a lot of great evidence of dialogue. I really appreciated that this kind of tool brought conversations. It seemed as though, of course I wasn't there, but it seemed as though some of these were new conversations or included people that hadn't previously been part of improvement conversation. That's terrific. You mentioned that the tools helped with staff buy-in. They understood a little bit more about why you were thinking the way you were, why you were trying to make changes, and noted the really variation among the perspectives of your team members, which is perfect. That's exactly what we want to see when we're looking at complex systems. No one person has a view of the entire system. So it's really helpful to have the people that do the work actually talk about opportunities for changes, things that are working well, and things that people are working around. They don't always talk about it, but that's what they do if systems don't work well. There were some good, honest conversations about some of the challenges you face. And then what we noticed was that you really had clarity about the big rocks, the things that you wanted to tackle. You were able to get those from the tools. What we weren't able to see when we asked for next steps was clarity about where to start with PDSAs. And I know we talk about PDSAs a lot, but they're such a powerful tool. And we wanted to reinforce by taking the opportunities that you see and making sure that you're comfortable using this very powerful tool, the Model for Improvement and PDSAs. So the faculty looked at that, and we decided to focus right here. So in between the prioritized changes and testing change ideas, in order to get there, you have to decide which ideas to test. And this is not uncommon, just to say this up front. Teams often struggle here. They get a little overwhelmed with all of their options. And sometimes it's hard to take a big idea or something in general that you want to tackle and make it really small, test of change. So that's going to be our content for today. We're going to focus right here and try to get you to the place where you are absolutely wonderful PDSA creators by the end of this time. So where we are, you've thought about the root causes. You've done a great job with the fishbone diagram. Then you took those, you prioritized those with the tool. And so what we want to say up front is that what most of us do, me included, I did this for a number of years, is we think of things that are easy to do. So we have a problem and we want things to be different. So we tend to think about things that are easy to do. And unfortunately, it's not always true that those things are aimed at a system level. We tend to think about people first. How can we change people's behavior? So we're going to remind them more. We're going to audit. We're going to compare data. We're going to see who's not doing what they're supposed to do. And it becomes kind of a punitive type of hunt, if you will. And it seems easy to go after the people, but actually those people are not doing their best work almost always because there's a system level challenge underneath that. So the things that when I saw a little bit about this in your homework, that you wanted to do more reminders and audits, and there's nothing wrong with that, especially if you're trying to embed a new system in place. So if you're just creating a new workflow, you may want to audit it as you're implementing it to see that it's taking hold. But over a long period of time, these reminders are short-lived. And a lot of the time, it gets frustrating as a staff person to be constantly told, you're not doing this, you're not doing that, and audited all the time. So what we really want to do now is focus on those system level changes that make it easier for people to do the right thing. You're going to see improvement in the way that your staff follow, especially if you have the buy-in of staff as you're coming up with these system level changes. But that's what we're going to spend the bulk of our time. So in order to get to system issues, I went back to my friend, and I know some of you, many of you have this guide, the improvement guide. And as you're looking through the improvement guide, there's a whole section in there, if you want to read more, that talk about 4 approaches to really get down to that system level and make the changes that are really going to make a difference in a system that you're trying to improve. And those are the critical thinking, using technology, creative thinking, and using change concepts. And as it happened, I was pretty excited. You know how nerdy and geeky I get, but I was pretty excited because I saw within your homework an example of each of these. So you're doing this work. The only next step is to design that PDSA. So that's what we're going to work on now. So the first approach to getting really down to the system level is to think about critically. So thinking about the system that you have now, remember the system that you have now to manage diabetes poor control is giving you the data that you're seeing on those little charts that Tina shared with you. So your system right now, that's your performance. If you want to improve it, one way is to really think about how the system works. Does it work the way you want it to? Are there gaps in the system? Are there places in the system that frequently fail? And how do we identify those and how do we improve them? And so you likely had a lot of these conversations during your fishbone exercise. You talked about the things that weren't working well for you. And so you have a good start about thinking through what might help to change. And so one example, and I told you I was going to pick on people, but not in a bad way, in a good way. I want to just call out Moses Lake. They used a nominal group technique. They had challenges with the lab process. And actually the next step was to create a PDSA. And so I thought that was a perfect place to start. And I'm wondering if team members from Moses Lake would be willing to just say what you're thinking about. What kind of PDSAs are you thinking about? And have you designed any yet? So who's here from Moses Lake?
Hi, this is Heather. I'm assuming you're referring to Moses Lake Community Health Center?
Yes,
Okay.
I'm sorry.
Oh,
I should say that. That's a city. It's a town in your region. Moses Lake Community Health Center. Thank you, Heather.
Okay. So sure, I can speak a little bit about our plan for diabetes, which you pointed out, timely labs has been a huge thing. We do have a lab here in our clinic, and patients are supposed to, if their A1Cs are elevated, they're supposed to come in either every 3 months or every 6 months, depending on what their A1C actually is. And we do have a really good recall system that we send letters, we make phone calls. But unfortunately, patients are still very reluctant to come in. And we've experienced that just as I'm sure as everybody else has due to COVID. And so one thing that we were testing out, or we're getting ready to test out, was enhancing our morning huddles with our healthcare teams. And we were going to start inviting one of our front desk reception staff members to our morning huddles. And so we would call the patients the day before to remind them to come in the morning for their fasting labs or whatever lab work they needed. And so that was our PDSA that we were looking towards testing out over these next few weeks, is incorporating our back staff and our front staff in the same morning huddle and reaching out to the patients the day before to let them know what to expect at their appointment. And so because oftentimes the patient will come in without their labs done, they'll go to their appointment, they'll meet with their nurse care manager, and then by then they've been at the clinic for about 45 minutes. And so they don't really want to go back over to lab to be at the clinic for, another half hour, 45 minutes. They just find themselves walking out the door. And so we're trying to see if we could get them to come in for their lab work before their appointment if we had a better success rate. And so the way we were going to be doing that was enhancing our morning huddles. Did that answer your question?
It does. That's a great example. So let me just show you a way that I bet you went around thinking about it. So they're due for an A1C. They have one ordered, and then between the order and the patient getting tested is where your system is breaking down. It's not the way that you wanted it to be. And so you ask some questions about what component of this system is not working. And you decided that the patient is not getting tested, and you decided to bring front desk in. What do you hope to learn from front desk that's going to help you understand why patients aren't getting tested? Or is it to reinforce that the testing should happen before their visit?
So essentially frontline staff are kind of the face of the clinic. They're the first ones that a patient comes in contact with. And so we're really just interested in learning from them. Our patients stopping on their, we don't really have a checkout system in place either here at Community Health. And so we're curious as to bringing them back in our morning huddle, because they're the first people to greet the patients when they walk in the door, and they're the last people to wish the patients farewell as they exit the door. And so we're interested in seeing if they're experiencing patients coming out of their appointments and going to the lab to get that done, or if they're just kind of the flow and the feel of the clinic and how patients are moving around the clinic, and how we can better enhance. We do have a lab. It's located on our first floor, kind of in the back corner. Maybe patients are not liking going over there. Maybe if we did a blood draw in the room rather than over in our lab area in particular, I think our front desk staff would be able to kind of deduce some of that from the patient flow and the traffic throughout the clinic. And so just a different, fresh perspective.
Great. So it's one of the wonderful things about a PDSA is very quickly you can learn a lot about this section of your system by collecting data in this way. I think this is a very creative way. I love that you involved additional staff. That front desk person is one of the most unappreciated and has one of the most difficult jobs in the clinic, is that front desk person. As you say, Heather, very, very timely. It's the face of the clinic. So great example of a PDSA, a plan to involve front desk in the huddle. Questions for Heather? So now I'm going to move to family health centers. So family health centers, they were looking at what the barriers are to completing a depression screen and documenting a follow-up plan. And they too looked at their workflow. They knew that the PHQ-9 was due, and they had a good process for that. What they found was that this area right here was in question. And sometimes it was done and sometimes it wasn't. And in looking at some of the reasons for that, they came up with some challenges in the workflow between behavioral health and primary care, and some of the expectations, the integration, let's just say the integration piece was not working smoothly. So can somebody from family health talk about how are you thinking about learning more about this part of your system, or what PDSAs have you been talking about?
This is Ton. I have to say the second shot of COVID puts our staff out for a few days, so we're a little bit behind on this work right now. So keeping that in mind, we have a meeting tomorrow with the BH director and one of the clinic operation managers. What we're finding is that our MAs, because of all the demands of both doing the COVID closet for testing and giving the vaccine, they don't have time. This PHQ-9 is not making it on their priority list. But we do have some behavioral health staff that are in the clinic that could be used. We're going to start with new patients. And what does that look like? Like, how can we use the behavioral health staff? We have case care coordinator and a case manager to come collect the PHQ-9, and we're looking at the SDOH work as well for that patient while that patient's in the room waiting. And this sounds obvious, I realize that, but it's not in the workflow. It's integrating two departments even further than they are integrated. And we've got to get down to those nitty-gritty steps of what's going to happen. And we plan to do that PDSA on this Wednesday, I believe.
That's great. And it's fine that I understand COVID, but you explained that so well. So you found a place where the work just wasn't getting done. It was just too much for the staff as assigned. So you're trying to find an alternative workflow. And in order to do that, you're doing some things to set it up. You're going to talk with the behavioral health supervisor and talk about what's possible. And then the opportunities to test that workflow. It could be at different points of the visit. It could be coordinated back and forth with MAs. There's a lot of different ways this workflow could go. And so this testing very small workflow, maybe one workflow, try it this way, try it that way. It's a great way to test and see if you can smooth out that work that's not currently happening. So thank you, Tom.
Yes, and I have to say, we also, this is more, I don't know how to PDSA this, or it's more of a soft thing, but I also had to float this idea in several different types of leadership and management meetings so that we'd have leadership buy-in when we went down to this change. Like, if we do change this, I need to know that our leadership's going to support us in the change.
Right, that's a great point. That's the people part of change management. You definitely can't change somebody else's department roles and responsibilities. So very smart to engage them in that work. Great. So there are some ideas about critical thinking about the current system that you have. Are there opportunities, if you identify them, focus that PDSA on a part of the system that seems to be giving you some trouble? So that's one way to think about creating a PDSA from an area that you're concerned about. Another way is to use technology. And many of you use prompts and reminders in your electronic health record. That's an example. Many organizations can automate throughput. So they automate when somebody comes in the front desk, they automate it so that the back office knows. So there's uses of technology that can help us solve a problem, solve the system level problem. A couple of
Is it just me or did we lose Kathy?
No, we did. So it said the host muted me.
Oh.
Okay. All right. Well, maybe I wasn't saying something right, but I'm here back. So just a couple of caveats. We all love technology, and we really rely on technology. And so if you have something that's not working, just automating that thing that's not working is not going to help. That seems like a no-brainer. You don't want to use technology if it's just one person or one team, or it seems to be a problem with a particular site. You want to dig in and not just automate that. And unreliable technology is worse than none at all. I remember talking with teams who used Messenger, and they used Messenger to communicate among their clinics. And what they found was that not everybody was using Messenger, so it stopped becoming a reliable way of communicating. And at the time that I was talking to teams about team-based care, it was kind of a nightmare. So it was an automated solution, but it didn't work because it wasn't reliably used. So it's not always the panacea that we may think it is. One way I saw, though, was Children's Home Society. They realized that they were not reliably screening for depression. They used a nominal group technique to figure out what seemed to be the problem. And they found that there were 3 areas that seemed to stand out. The clinicians just, it was new to them. It was something that they didn't remember. Sometimes clients don't show up. But I think one of the system level things that they saw was that clinicians forget, but there's no organizational workflow that had been developed. So there's no underlying system to prompt those clinicians. So even if they wanted to do it, it's harder for them to do that without that infrastructure. So they discussed planning to develop an Excel spreadsheet to track, and that's going to help them understand what the need is, what the work capacity needs to be, and they're going to understand a lot of data about what it's going to take to screen for depression, and then they can develop that workflow with that information. So I'm wondering, is there anybody from Children's Home Society on the call?
Yeah, I can speak.
Great, wonderful, thank you.
Yeah, so the PHQ-9 is definitely a new assessment tool for our agency. And so exactly as you said, I think clinicians were forgetting to screen this. There wasn't really a workflow for us to implement that for them. And so this has been created so that now they have a system to be able to know when to score, how often. So we've gone from scoring or utilizing the screener at like intakes, but now at 6 months and monthly as needed. And so then we did create those Excel spreadsheets. So when they are screening those, they have one individually for each therapist to be able to report monthly who they screened, what the score was, what their diagnosis was. And then that way I, as the coordinator, can go back to that monthly to be able to collect our data.
Can you give us just the early version of how are your therapists reacting to this new, it's a new task for them, it's more work, but what are they saying about what you're doing?
You know, I don't have too much information about that yet. I think that that's what's in the works to see how they are responding to that. I think they're just used to having to do other assessments in general. So it's just another one added to their list that they're usually that they're used to screening anyway. So I just don't have too much feedback currently.
Great. So again, your PDSAs will be looking at how is the Excel spreadsheet being used? What do you learn from it? What are the things about the workflow that we can develop that's informed by what you learned from the spreadsheet? So that all ties into that next learning so that you can really get down to that system level change of creating that workflow that's a part of the way that Children's Home Society does their work. Another opportunity, so we've talked about critical thinking and we've talked about technology. Here's another one, and this is just creative thinking. And that is really where you, a place where you don't have a system in place yet. So you can't really critically think about it. And you may have a lot of beliefs in your organization that there's something that is being asked of you that you either don't want to do or you're not comfortable doing. It's a good way to have a conversation in a safe space and talk about those boundaries that we sometimes place on ourselves. So instead of thinking how might we think of all the reasons why we can't possibly do whatever is being asked of us, and rather really focus on the need. And I thought that the center had a really great example of a session where they were creatively thinking. So their issue was that the providers didn't really understand the reason why they had to do PHQ-9s. And they had a lot of reasons why they didn't want to do PHQ-9s. And they held that space to be able to talk about what the issues really were. They felt vulnerable because they weren't used to doing that kind of thing. They weren't sure what happened when the PHQ-9 was positive because they don't have a behavioral health specialist on site. So what do? You know, don't open Pandora's box. You might find something in there you don't like. But because they had that conversation and they opened up the boundaries, they began to think about how might we do this. And they talked about the rationale and the need for it and the overlap between substance use disorder and depression. And so I thought they had a really nice way to think about how they could have that conversation and really move forward and not have it be a top down. They really engaged all of their staff. So from the center, Loretta and Paul, would somebody speak just to that experience of opening it up and thinking creatively about this dilemma that you have?
Okay, now what is it? Sorry.
Tell us about the conversation when you were talking with your clinicians about doing a PHQ-9, and they were not thrilled about doing it. You were clear about that, but you had a conversation. The center had a conversation that really changed their thinking about that. And you held space and you let them have their voice. And I thought it was really cool what you did. So tell us about that conversation.
Well, it kind of started with the nominal group survey we did. And of course, that opened up all kinds of conversations about the way it was done, and which was great. But then when we started looking at the force field and the resistance, it became really glaring that there's one part of our staff that we have never asked for input from. We have not even clued them in as to why we're doing all of this stuff. And that's the people that are supposed to be doing it. So that could be the reason we're not getting a ton of follow-up. And so we plan to have a conversation with them, with them. In fact, we booked it for tomorrow morning. So we'll be kind of letting them in on everything and asking, how do you think this will work? How do you think, what do you need for a reminder? What do you need, or what do you think? And how do you think we can do this? Because we don't know, and see what they do with it.
Great. So those of you who are stuck, where you have a lot of resistance, this is another way to open up the boundaries, challenge the boundaries that some people have, and really open up the dialogue. And I could sense the enthusiasm when the conversation turned from all the reasons they couldn't do things to ideas to make it work. So there's that transition that's just really lovely to see, and you explained it so well in your homework.
Thank you.
All right, and last but not least, change concepts. So we have bothered you to death about change concepts ever since the beginning of this initiative. And we've showed you some change concepts, but change concepts are ideas that have a high chance of being useful to make a system change. And some very generic change concepts are listed in the improvement guide. If you do have access to that book, you may remember way back when we were doing the change plan, we gave you change concepts to choose which ones you might focus on and tactics within them. So change concepts is the fourth and final way that we'll talk about today that you can get to system change. And just a reminder, these are the drivers, and these change ideas fall under each of these drivers. And these drivers are intended to really focus you on the attributes of the system that need to change in order to make improvements for your population, especially around A1C and depression screening monitoring. And remember, they're there for you. They're still in your change plan should you want to look at them. But what I saw was an example of looking at this particular screening. This was from a webinar 2018. We've been talking about this for a long time, but we talked about the importance to systematically screen for risk due to complexity, severity of conditions. And that's exactly what we're doing when we're screening for depression. And we talked about these examples. So a lot of your work incorporating PHQ-9 and trying to document screening and follow-up, these are examples of change concepts that are in your change plan and part of our population health LAN. So again, this is another way that we know that getting down to things that we know have worked for others and may work for you is a really good area to focus your time. So that's really where this screening idea came from. These high leverage change ideas come from the improvement guide. And as you're going through some of your look at your flows and your workflows, trying to look at some of these and think, you know, are we having trouble? So synchronization means that you need to have the information, or one step in the process sometimes has to be completed by another. You have to synchronize the timing. So if your provider is supposed to act on depression screening and the depression screening hasn't yet been done in the workflow, that's a problem. And so you've got the workflow backwards. That's synchronized. Scheduling into multiple processes. So I've already heard from a couple of you and saw in your homework that one of the areas that had been missed was the PHQ-9 wasn't in the new patient packet. So you forgot to screen new patients. So those kinds of high leverage things, trying to do tasks in parallel. So it's not just one finishes and the next one starts. And I know all of you do this, where you've got your MA is doing something and your provider is doing something else and your front desk is doing something all on behalf of one patient. So parallel tasks. So these ideas really speak to how can we make that system as efficient and as effective as possible. So we can come back to these ideas when you're struggling, because we know that these attributes of a good system ring true in all different kinds of organizational strategies, not just in healthcare. Other ideas that we have seen is reliability. So we have a procedure, it happens sometimes, but it doesn't reliably happen. And we heard about some examples of that earlier today and looked at reminders in the EHR, looked at the huddle, trying to remind us to get A1C, the lab. So these kinds of things, just making it easier to do the right thing. So these change ideas are available for you. And again, in the book, and we have the book. I have the book always at the ready. I can always reach it. So if you know, if you're struggling with system level changes, let us know. We're happy to help. And I want to just, we just have time probably for one, but I want to call on Cascade Medical. And what they did was they looked at depression screening barriers as well. And they came up with a list of patient issues, provider issues, and workflow. And so this one I thought was really cool because in addition to the reminders and the PHQ form in the new patient package, which I already mentioned, one of the staff members discussed how she managed getting a PHQ done during a virtual visit. And I had the sense that some providers were more successful than others in actually getting that to happen. So I'm wondering if Cascade Medical, if you could just speak to that portion, how did you, Brenda, influence the system of how providers talk to patients during a virtual visit to help them understand the importance of the PHQ-9? What can you tell me about that conversation? Anybody from Cascade on? I may not be seeing everyone.
Hi, can you hear us now?
Yes, wonderful, thank you.
Oh, perfect. Okay, thank you. So when we had this conversation, several of the support staff said, well, it's uncomfortable and we feel strange asking these questions over the phone or over the telehealth visit while we're preparing the visit for the provider. And Brenda, who, bless her heart, we call her steady as the sun. She's there every day. She does everything we ask her to, but she's very quiet. And she pipes up and she goes, I just explain to the patients why we need this information, and then I get their blessing, and then I ask them the questions, and it takes me, 2 or 3 minutes. She goes, I don't seem to have a problem. And so I think hearing Brenda say that was kind of inspirational to the rest of the team. So that's how that came about.
And so this is an example of sharing best practices among providers. If somebody is doing something well, sharing what they're doing with other members of the team is a great strategy to improve the system. This may lead to something called scripting, where you suggest an approach to a patient who needs a PHQ-9. How do you approach them? How do you engage them? That leads to maybe you could engage a patient to say, what's the best way to engage you to do this or to understand it? So these are examples of using tried and true change concepts, of standardizing the workflow, using best practices, sharing among team members. So it's a great idea of using a change concept to make a system improvement. So that's all of our system improvement. I'm sorry, I don't have time to go through all of the teams, but every one of you did something that was really cool that fit into one of these system changes. So now what we want to encourage you to do is really think through, based on what you want to focus on, what is one small step you can take? What is that PDSA that you can take? And you can see I've got all these other folks here. We just don't have time. So what we're going to ask you to do is actually create and do a PDSA. Now, in order to get that done, it has to be very, very small, because you don't have time to do a big, long planning session. and you don't have time to do it with a lot of people or a lot of staff members. So it can be as teeny tiny as you can make it. It can be a PDSA involving one patient or one staff member or one anything. It can be really, really small. But we want you to take what you came up with from your tool, the area that you want to work on, and create one PDSA. Now, the template that I've given you is from the Institute for Healthcare Improvement. I know some of you are new in your positions, and part of that template is an example of a PDSA form filled out. So in case you're unsure or you haven't done it before, please look at the example that's there. It's quite good. And also know that we're all here to help you. We want to help you with this PDSA formation because we know that's one of the best ways to get you really testing changes at that system level. So I'm going to stop there and see if there are any questions. Questions, comments. If anybody is unsure after today how to create that Plan, Do, Study, Act, we've got Mariah and Wendy are chomping at the bit to help you. We're here to back you up. If you have any questions for us, we really think this is a great opportunity to really get down to that system level. And we feel pretty sure we're already seeing some good signals. I'd love to see us be able to move the dots here in the next few months.
Kathy, can I ask, the homework is going to be due on the 19th. So for their homework, they're not going to have time to actually completely do the PDSA. So would their homework be just writing up their plan of what they're planning on doing?
You know, I think since it's due the 19th, I'd really like to challenge teams to do a PDSA. It can be one thing, one patient. What we see most often is that people spend a lot of time and energy planning and kind of dithering about what they're going to do. Just jump in and try it. So say for the example that we just went through. So somebody who hasn't had good luck with engaging a patient to do a PHQ-9 over the phone. So your PDSA could be to have that one person try this new way that Brenda just taught them with one patient and write down what happens. And that would take a very short period of time. That's all we're looking for, one PDSA, very small. And we talked about this as a faculty because we initially were just going to have you do the plan, but we know that teams get stuck, and once you get used to these, they're so much easier. So really, really small so that you can get it done, go for it. If you can't do it, don't stress, but if you can go for it and try to get that PDSA, one PDSA done by the 19th and post it. Thanks, Wendy. Any other questions? Please go for the evaluation. We do look at it every time. We look at it as a group for us to guide you. And next time we're going to be talking about accelerating change. So now that you're used to making a PDSA, how can you spread those changes more rapidly throughout your organization? And that helps us move the dots more quickly. So that's what we'll be talking about in March.
And the evaluation link is in the chat box right now.
Thank you all. Have a great rest of your day.